So my name is LeAnn Shaw, and I work as a behavioral health consultant at Pediatric Partners of the Southwest. I've worked for them part-time for the last 4 years, and the last year full-time. Well, close to it. I've had some medical challenges. But today I was going to bring one patient example just because I think it elaborates several system pieces that we're having challenges with. So my goal of coming today is to use a case example of the challenges working with the adolescent population when services are not available in this area and the frustration to access higher levels of care for adolescents in need. The patient in question that we're talking about today is a 14-year-old Hispanic female who was adopted from the foster care system. She has struggled to engage in previous years due to high turnover of providers with Access Health System. The patient would have really benefited from the RYFS program, but keeping that position staffed has been challenging. That's a position between the Department of Human Services and the Community Mental Health Center, but they do home-based work. The patient finally engaged when we opened up a Bayfield clinic and has attended multiple individual sessions and numerous co-visits with her primary care provider. I believe this engagement occurred for 2 reasons. 1, the location was convenient to her home, and 2, the patient felt connected with the integrated care model. Seeing the doctor and the behavioral health at the same time was very effective for the parent and the child. The patient has attempted suicide twice in the past 9 months. Both times she was taken to the ER and evaluated by Access Health System crisis team. Both evaluations resulted in a safety plan with the mom of client who had allowed the patient to access her medications that she was using to overdose on. When reviewing the crisis assessment, the risk factors did not reflect the severity of the situation, and the recommendations that were put in there are not accessible in our rural health system, such as intensive outpatient therapy. Despite stating that the family needed therapy, Access did not schedule an intake for the family or make any further recommendations. The crisis worker both times did not consult the primary care provider or the therapist who works with the family. If the crisis worker had reached out to our offices, then we could have shared our concern for this patient's high risk and the need for additional supports. The patient is on medication and is working with Children's Hospital of Colorado Psychiatry through our telemedic clinic to manage her meds. She's been referred to Radical Possibilities through La Plata Youth Services, but has not yet had an intake due to coordination with her mom, and has asked for equine therapy, thinking it's been very beneficial in the past, but the cost is $75 an hour and they don't accept insurance. In the spirit of doing the brief therapy model, which we are asked to do in the integrated health setting, I've been working to refer her to an outpatient therapist who can do regular, ongoing, intense weekly therapy, but she's been in crisis and transitioning many times, and it's not the best practice to push her out the door when she's falling apart. The patient also has a brother who has severe mental health and physical health challenges along with substance use. He is in his 30s and on probation and living in the home. He has a history of being physically and verbally aggressive towards the mom and the patient. Access has been trying to get him into a co-occurring program such as the Circle program, but he's been on the wait list for over 6 months without success. During that time, he has assaulted the patient, yelled and threatened the patient, and the police have responded to their home numerous times. The police now refuse to take him into custody unless a major offense has been cited because he cannot get the medications he needs in jail and his health is too fragile. And it's not because they don't do meds, they do, but they have certain restrictions on the meds they do. He is also an Access patient. Access has failed to find housing or inpatient treatment for this patient in the past year, and his behaviors are negatively impacting the patient that I see. Mom has now lost her job and is struggling to find work. They are in financial crisis, and this is escalating the patient's issues as well. A successful plan would be to have a community case manager that can work with the family to obtain resources such as including food, financial, work supports. A therapist and a case manager should be working with the adult sibling to help him find housing and treatment for his complex issues. The patient needs to have individual and family therapy weekly to improve her dynamics and reduce suicidal ideations. In order to improve the quality of care for this family and others like her, we need to improve communication between agencies, along with making plans of care that are accessible and feasible that are effective. I feel that collaboration, communication, and other levels of care in our community, such as in-home or community-based case management, safe respite, and a higher level of care for adolescents being more accessible to our area.